Ladies and gentlemen, shh. Good morning, bonjour, good morgen. Welcome. If you'd like to take your seats. For those of you who weren't at the dinner last night and are joining us this morning, a very, very warm welcome from me. My name is Nick Ross. Like most of you here, I have a personal and professional interest in pain. I suppose most of you do, as physicians, as patients, as carers, as campaigners, as policymakers, as politicians. We have rather outgrown the European Parliament, which is why we're here. In fact, it looks rather sparse, but we are, in fact, almost 200 people here, twice as many as at last year's SIP. And I'm sorry you've had to be moved all around the place from the European Parliament to the Bibliothèque Solvay at last to here. But it's a nice environment and a very warm welcome from me. But the welcome that means something is from the President of EFIC, whose conference this really is. Ladies and gentlemen, Chris Wells.
Thank you very much indeed, Nick. Ladies and gentlemen, I'm, as you've heard, the President of the European Pain Federation, 37 countries throughout Europe with 20,000 healthcare professionals. And I want to welcome you to this wonderful meeting. You've heard already from Nick how things have surpassed our expectations. And this is thanks to certain people, and I want to thank Marian Harkin for hosting the meeting, and the Italian government in particular for putting pain and its management on the map. Because during their presidency of the EU, they called for prioritization of pain therapy and palliative care, culminating in a meeting in Milan in September, hosted by Health Minister Beatrice Lorenzin, in which they made the decision that all of the EU ministers on health, they made the decision that there should be ensuring of training of healthcare professionals in the sector, an exchange of information on effectiveness of therapy for the weakest population group. That's 100 million people throughout Europe. So this is a huge number of people. The societal impact of pain is huge. It's an impact on patients and on society. And that's what we are looking at and have been looking at for 5 years. And this is the 5th symposium. But as you heard, it's by far the biggest. And that's because this wonderful initiative of the Italian government. By helping to ensure that we look at and help ease the burden of pain on these patients and on society, I think we're going to make a huge contribution to Europe. I want to thank you for sharing our passion and for being here, and welcome to the symposium. Thank you.
If you think about it, it is perfectly extraordinary that we have to meet here. The first analgesics we know about are literally thousands of years old. And for 100, 150 years, we've had all sorts of array of modern analgesics. Tree bark, which was eventually synthesized into aspirin, all sorts of other NSAIDs. We've had chloroform. We've had all the other forms of anesthesia. We've developed cognitive behavior therapy and all sorts of psychological treatments. We know a lot about pain now. We know it isn't a simple wiring system. We should be in a position to, if not conquer it, at least manage it much, much more effectively. So why on earth is it that in 2014, huge numbers of people in Europe still suffer considerable amounts of pain? There are different terms people use: chronic pain, persistent pain, whatever. But we have something of a crisis, and we shouldn't have. And SIP is determined, and we must be determined, to make sure something actually results from what we talk about today, so it isn't just talk. What do we do to make sure that we really do bring this issue into the 21st century rather than the 18th or 19th, which is where much of the time it resides? We've got 4 panels. We've decided to do this in an interactive way. The first panel, unapologetically, we're going to set out what the problem is. Many of you will already know what the problem is. But there are policymakers here, and I'm very pleased at the number of politicians here for whom this will be a relatively novel issue. So what is the problem? How does it affect people? How does it affect society? Secondly, we're going to be looking at, well, what are the options? What are the solutions? How can we find a way out of this? The third panel is going to be looking at the Italian initiative, not particularly in its own right, but simply as, well, as a springboard. How can we leverage from that? And the fourth one is, how do we really take this forward? How do we create milestones? How do we create benchmarks? How do we measure our progress so that next year when we meet, we really have got some idea of how far we have brought the issue since we started. Good panel here. Hans Kress, former president of the European Pain Federation. Sheila Wright is a nurse who's written a textbook on pain management and has advocated better training, especially on the link between psychology and pain. She works in Dublin. David Hughes is a professor of health economics at the University of Chester. Neil Betteridge is vice chair of the Chronic Pain Policy Coalition. And Maria Teresa Garcia Barroco is the coordinator of the regional palliative care program in Madrid. And as you may know, Spain, like Italy, has been making great advances in pain management recently. Hans, could you start, just for those who here don't suffer the burden of this themselves, don't see it every day, just what it is like for a person who is suffering persistent chronic pain, and how many there are?
I think my colleague Elliot Crane has perfectly set the scene. So it was an impressive and strong speech, and he has shown us what it means for an individual, for a patient to suffer from such a chronic pain, how awful it may feel. I think this torch was an excellent example. So chronic pain is something completely different from acute pain, and I think, again, Elliot Crane has perfectly shown the difference. Acute pain is our friend. Acute pain is our bodyguard. It is a normal response to a potential or to a true tissue damage. And it is a life-saving biological warning signal. And with the course of healing, it spontaneously disappears. And we all know that normal analgesic drugs work excellently against acute pain. In contrast, chronic pain is something completely different. It is an uninvited and constant companion of a chronic pain patient for years, maybe for the rest of life. For the patients, but also for the physicians, the end of chronic pain is unforeseeable, and therefore chronic pain has so many psychosocial consequences. Negative thoughts, poor sleep, anxiety, depression, social isolation. Besides depression, also the daily activity, physical activity is difficult for a chronic pain patient, and therefore these patients become more and more disabled. And finally, chronic pain is notoriously difficult to treat. Elliot, again, has shown this. Normal analgesic drugs don't work against chronic pain. There is no magic drug, no magic remedy that will be effective against any type of chronic pain. What we need is a multimodal, a multidisciplinary approach to treat such a complex phenomenon as chronic pain.
I don't know if you saw the recent paper which shows very, very effectively, and some people will be surprised at this perhaps, that there is no correlation between chronic pain and people's education or income levels. Now, I say this might come as a surprise to people because there is quite a lot of, at least anecdotal evidence, that physicians and indeed lay people think, well, it's an excuse. That person doesn't want to work. It actually works the other way, doesn't it? It's the chronic pain that makes it difficult for people to work. David, just tell us what the social consequences are of pain, the numbers involved, the effect it has on our economies.
The numbers are almost incomprehensibly large. 100 million people in Europe suffer from chronic pain. It translates into 500 million sick days lost as a result of chronic pain. 34 billion euros has been the cost estimated. These are direct and indirect costs, so it not only affects the ability to work, one in 5 people lose their job because of chronic pain and can't work because of chronic pain. It affects families. It affects our ability as economies to grow. It's been estimated between 3 and 10% of GDP is lost because of chronic pain. These figures are enormous. People in chronic pain utilise health resources much more intensively than any other group. 4 or 5 times the utilisation levels across the board in primary care, hospital care, medication. So these are consistent figures that we're seeing. And the impact on individuals' quality of life. People in chronic pain have a very poor quality of life compared to other conditions, purely because of pain. And I think one of the most distressing statistics, because these are such big figures, they just look like statistics. Until I read the statistic, 1 in 6 people feel that the pain's so bad they would prefer to die. That's what we're talking about. It has a personal cost, a societal cost, an individual cost, and a cost to families. And that's a distressing issue, an enormous issue, and one that we simply can't afford to ignore.
Do you think policymakers believe these estimates? Estimates are notorious because sometimes they're wildly wrong. They are often just projections of small samples. Mark, you have been quite careful. You've said that it could be from 3 to 10% of GDP loss. That's a big spread. But if it's so major, why are policymakers not making this such a priority?
And I think that's a complex, it's a complex area. My personal view is I think policymakers might be concerned about opening a Pandora's box. If indeed 1 in 5 people are suffering from chronic pain, that feels expensive from a policy-making perspective. It's about prioritization as well, I think, and also about what we can do about this and whether we should do something about this. As we were saying earlier, acute pain is very different. It's a signal, and it's something that we go through and goes away. Chronic pain is an entirely different.
Sheila, in your experience, you work particularly with cancer patients. There's no question. People aren't malingering. There's no policymaker, no doctor who can say, well, you're making this up. And yet still, we're quite barbaric sometimes in the lack of proper pain management with cancer patients. Why? Why is this persisting into the 21st century?
Nick, it's really from a perspective of knowledge, lack of knowledge and lack of skills. In Ireland, in the context where I've been working, the developments in the last 20 years are phenomenal. The whole service has revolutionized. And that is down to having a very good national cancer strategy. That made a huge difference because with that strategy in place, the services were able to reorganize and reform and form cancer service centers of excellence with good reference and good referral pathways and good service development, more clinical nurse specialists, vastly more numbers of clinical nurse specialists for different types of cancers. And people became more interested in becoming competent in pain management. So my knowledge of where we are in cancer care actually is far better than where we are in care of chronic pain of non-malignant origin currently. That's where the real knowledge gap is now in Ireland.
So it's not that physicians don't care, it's not that physicians, perhaps sometimes you need to, as a physician, develop a carapace, develop a hard skin so that it doesn't get you emotionally. That's not the reason that the patients aren't being treated properly. It's simply I'm not a physician, but as physicians, as surgeons, they don't know enough. It's not part of the curriculum.
This is the whole problem. The core curriculum at the moment at undergraduate level is very much being got at in spots. what needs to happen is a sea change. There needs to be mandatory legislation to introduce undergraduate training in pain management for all disciplines across the multidisciplinary team. Until we have that, we're not going to have standards that are adequate for meeting patients' needs. Certainly, we have not being dishonest, being really, really honest. We have a problem. And we certainly see that in Ireland at the moment. We have a knowledge problem. And until we meet and address undergraduate education in pain management, that problem permeates up the whole system to management level. And what happens is we get poor decision making because of lack of knowledge, and that impacts on patient treatment and ultimately patient safety. And we have examples of that happening that don't become public. They're not high profile, but when you're in the system, you see them happening regularly, and you know that they're down to lack of knowledge and lack of skills.
There's absolutely nothing to stop individual countries having a national strategy. It's beginning to happen in Spain. I'm interested, Maria Teresa, why? Why Spain? How did you get it going?
We got it going because we saw the need. And when the need is obvious, and from 17 different regions, we all pulled together, and the central government called us. It was very easy to participate. As an expert, if you're asked for your opinion, you want to do the best for your patients, for your countries, and to project your own experience into the big picture.
Has it been successful? Have you really seen a big change?
Unfortunately, I was in the UK when all this was happening, but I was lucky enough to come in 2008 when quite a bit of money was given per capita. And I found myself having to coordinate palliative care for 6.5 million people, one of which are children, with quite, I felt, and don't quote me, abundant money. We were able to say each euro should go to the most of people. So we set up a very strong palliative care program, a training program that was compulsory to work in palliative care in Madrid. And that has, within 6 years, changed the picture quite dramatically. We also worked around some of the issues that Sheila was talking about, setting up respite beds to treat more just drugs, but to give families the chance to get themselves together. And that is showing to be very productive. And we've managed to get a 24-hour service, palliative care. And you won't be surprised to hear that most of the calls are from people between 69 and 82 years of age. And the most common reason for calling is pain. But people don't phone to say, I want a painkiller. They are phoning to say, I'm looking after my loved one. Am I doing okay? This is what I'm doing. Am I doing okay? Don't come out. Just tell me that what I'm doing is not going to do any damage.
You've raised so many issues there, but one that intrigues me is you talk about the fact that money, this required resource.
Yes.
And as we've heard from Sheila and Hans and David, one of the reasons perhaps policymakers are reluctant, and the medical fraternity is reluctant to get too deeply into this, is because we haven't got the money. All health systems are straining so badly. And I wonder, Neil, from a patient's perspective, is that the problem, that there are so many patient groups looking to get more money for research, looking to get more money for rare diseases, looking to get money for all sorts of other things. There are so many doctors and nurses campaigning for different things. You're getting drowned out.
Absolutely, and I'm one of those people who's regularly haranguing policymakers that they should do more for people with chronic pain, rheumatic diseases, etc. But I know that the following day they'll have someone making the same case for dementia, and then in the afternoon it will be Parkinson's is the most important, and by Friday it's mental health. So I have a good deal of sympathy for policymakers, actually. It's not often said that one should feel sympathy towards politicians and so on, but it's a really difficult job. they're not the experts in any of these conditions. We really need an ask of them, I think, a volition to support, to create a framework in which the real work has to be done by the kind of people who are in this room. And the way I think we can make chronic pain a disease area which is more attractive, therefore, to policymakers, and where we might, therefore, see some extra flow of resource into research and so on, is if we can establish clear goals. You know, we get the evidence base, we get not just lots of data, but the right data that really illustrates the problem, and that we put a human face on that, because ultimately it is about people. But more than anything, we offer solutions, and we offer to do the work which will get us to those solutions. So, you know, I think going back to the issue of the numbers that we've discussed already, I think sometimes the large numbers are our enemy, because a policymaker may have 6 months or 5 years, perhaps maximum, to carry out a program of support. And if we start talking about 100 million people who need something, well, either, as you say, Nick, that's not necessarily credible or believable, or on the other hand, if it is, what are we going to do? And I think we create a defeatist scenario. If we can be more focused on those cohorts of people where the pain is more severe, and where there are more specific solutions which we can deliver, then you begin to tell a story with the potential for a happy ending. Make it feasible, make it doable. So I'm old enough to remember a time when people used to write letters rather than emails to each other. And one of the things somebody said to me once was, you know, I'm really sorry, I sent you a long letter, I just didn't have time to send you a short one. And I think in chronic pain, we've got too many big numbers and too many priorities. If at the end of this day, this really important opportunity we have today, if we can emerge not with 10 or 20 recommendations, but 1 or 2 that we have consensus on, we'll have had a fantastic day.
Look, 3 things have emerged from this that I haven't really thought of as 3 things, separate things up to now. One is obviously resources. Let's think about that one. Another one you just talked about, which is a sort of fatalism. Not sure, we've got so much we can do, I'm not sure we're going to make any difference. And that's a really important issue. The other one is training, whether we actually know enough. Now, I just want to focus, if we may, for the non-resource ones. Because as soon as we go as a campaigning body and say, we want more money, we're going to encounter all sorts of resistance. But how much can we do ourselves? You know the expression, physician, heal thyself. How much can we do? If we take training first of all, Hans, just take us through, the Ethics did this Europe-wide study on training. I mean, it was extraordinary. 242 medical schools in 15 European countries, 82% of undergraduates had virtually no training in pain at all. Or at least no compulsory. They might have done something on the side. 82%. So, I mean, this isn't a resource issue. This is, come on, guys. Deans of medical schools have got to get their act together on this. How do we change that?
First of all, it is a shame. It is a shame that, as you said, so many don't see pain as a priority in education. How we can change it? We can change it, and we have started to do that by first of all proposing a core curriculum for education in proper pain management at the undergraduate level. This is published, accessible at the website of the European Pain Federation, and we have provided it to everybody for free who wants to use it as a whole or in parts to improve pain management in a country, at a university, in an institution. And I would take the opportunity to ask the Italian presidency. It would be great if under the Italian presidency now this core curriculum for undergraduate education in pain management could be endorsed so that it is more attractive for others to follow the example of the Italian government and other governments and to implement it, to improve the situation of education, because that is our future. We are educating future physicians. How should they properly treat chronic pain patients when they don't know how to do it, and when we as a medical community don't prioritize education? How should politicians then prioritize pain management? So that is a major task we have to do, and we know that, for example, veterinary medical students in veterinary medicine, they will, in some countries, I don't tell you in which countries, but in some countries, they will receive 5 times the amount of education in pain management than doctors. So in some countries, your dog, your cat, and your horse will receive a better pain management than your sister, your daughter, or yourself. So that is, I think, not an acceptable situation.
Sheila, we've been talking about doctors so far, surgeons as well as physicians. What about nurses? Before I came here, I was speaking to a British oncologist, one of the best ones, a surgeon, called Michael Baum, who specializes in breast cancer. He has long been exercised about the issue of pain management, post-surgical, so not necessarily chronic, but the concern that if you don't treat acute, it can become chronic. And he says often he's thwarted by nurses. Yes. What's your reaction to that?
Indeed, Nick. Again, it's the same issue. It's the lack of knowledge and skills. And this needs to take place at undergraduate level, particularly an emphasis on pain measurement. And this is a specific learning need, a specific learning objective, and a mode of education. Our formats, there are very basic tools that are quite straightforward to learn, but highly effective to understand what the patient's pain experience is, to work with the patient preoperatively so that the patient's pain experience can be ascertained during the perioperative period and adequately treated, so that postoperative pain is effective, not ineffective, and maximized towards an optimal patient pain outcome and overall health outcome. This is unquestionably the core of the issue of training and education in nurse education in pain management. It's understanding the concepts that underpin the need for measurement and assessment, understanding the difference between assessment, which is an overall picture of what the patient's pain experience is, and the measurement of their particular specific subjective pain experience at a given time, both numerically and in terms of qualitatively. Some nurses have a resistance to using numbers. We have to break down this major resistance and objectivity, negativity towards measurement, which we are encountering currently. This is, again, a confidence issue. It's an education issue. If we can break down and equip nurses with confidence and very basic tools, which are very clearly written out, and they're clearly written out in the IASP nursing curriculum, which is now in book format and being published at the end of this December. And very, very clear explanation on how to use a number rating scale, how to use a verbal rating scale, different types of very basic tools that can be used in the perioperative period with the patient. And the key is to train and educate the patient as well. So there's the whole focus on patient education as well as nurse education, and the nurse and the patient working together as a unit, as a team, to maximize the patient's outcome so that the patient understands what's happening when they're being asked by the nurse what their patient's subjective experience is of pain, being able to put a number on it, being able to put an adjectival description on it.
Maria Teresa, I just wonder how much there isn't a cultural issue here, though. I suggested earlier on that doctors, as part of their training, one of the first things a doctor has to do, my son's just qualified as a doctor, one of the first things he had to do, there's a cadaver, there's a dead body. In fact, he was shown a head. You can't be very sensitive and get through medical training, and there were some who dropped out because they found this too difficult. So there is that aspect, but there's also, I suspect, a cultural one. We saw last night how the southern Europeans have used less analgesics than people in the north.
Yes.
So before we start saying we need more resources, is there more we can do ourselves? Just say, come on, guys, get a grip. We have the answers in our own hands to a great degree.
I fully agree with you, and having worked in 2 different countries, I can see the difference. One's talk about having this stiff upper lip, and yet they have developed pain and pain control and management programs that we wish we had. And in Spain, we have more of, this is the equivalent to the NHS, this is my taxes are paying for this service, I want. And yet, and this is an important thing, we don't know what we want. Because I think the culture is also about us professionals. Cicely Saunders said many years ago that there is so much we don't know and we don't understand about pain. And I would say this is the first thing. What are we going to teach if we don't know and we don't understand? And this is one thing that I try to teach when I can. But the second one is we have got so many drugs, very strong drugs, at the disposal of anybody, used by the wrong people at the wrong time. They can create serious pain syndromes and problems. So I would also advocate to having some of the painkillers, analgesics, and pain-modifying agents just to be used by the specialists. Yes. And I think that would be a really good use of resource. And culturally, it would show we care about pain. We want to know more, and we want to have some sort of gatekeeping control that would give access to financial and economic resources to those who know what they're doing.
Caring about pain is one reason why I want to talk about acute as well as chronic pain. Yes. And I want to tell you 2 anecdotes which seem to me probably tell us a great deal about the medical profession and those who pay for the medical profession and run healthcare. They're both examples from the United Kingdom, which you regard as having, on the whole, a very good approach. And it shows that if this is good, heaven help the rest of Europe. One involves a man called Alistair Liddell, who rose to become number 2 in the National Health Service. He was a very senior figure. He was in charge of the strategy for the whole of the NHS. He fell off a ladder, only a little bit above the ground, but fell awkwardly, and his foot, I think, got caught in the rung, I don't know. He broke his ankle. The ambulance service, when it does triage, does not accept pain as an issue. When I spoke to them about this, their policy director told me, well, anybody can say they're in pain. And I said, yes, but anybody, if they want an ambulance quickly, can say they've got chest pains. Anybody can say that the patient is unresponsive. You having to go on what the report is, why are you disregarding pain? But they do. Now, he wasn't properly treated for pain when he was in hospital. And for the rest of his life, sadly he died very young, but for the rest of his life, he suffered from serious pain. It wasn't treated, it wasn't regarded as an issue, it started as an acute episode. It wasn't an issue. Another one is a personal one. Many years ago, I had an operation, and I suffered what are called post-operative adhesions. Now, if all the women here who've been in childbirth, if any of you have suffered post-operative adhesions, you'll know it's a very similar feeling. You go into sort of contractions, but in this case, you're not producing a baby. In this case, you can tear your gut apart, and it can be fatal. It's pretty frightening, and it's very painful. I've been taken to hospital 3 times. In one, pain was one of the first things they did. They gave me, in that case, opioids, which, as it happens, helped calm it down. The second one I went to, I was there for 24 hours before anybody gave any pain relief at all. So even with acute pain, we have a culture where we have no joined-up thinking, where people just do their own thing. If when you've got somebody brought in on twos and blues, as we say in the United Kingdom, on an emergency, and still you can't see the pain, still you can't treat it, how on earth are we going to get people to give a priority to someone who says, well, I've been in pain for 6 months, doctor. I've been in pain for 3 years, doctor. I think it seems to me the two are very closely linked. Do you agree, Hans?
Yes, I agree, because it depends on our education system. So for a long time, more than 1 century, we have been trained only to believe what we see. You can't see, as you said, you can't see pain, and pain is not objectively measurable. So it does not fit very well to our concept of a disease, because a disease is in the minds of our teachers, of our university teachers, and that has a long tradition. A disease is something that is related to a tissue damage, to a non-functioning organ, to a pathology that can be seen in ultrasound pictures, using other imaging methods like MRI or X-rays, or you will at least find something pathological in the blood chemistry. And if there is nothing left, no pathological changes that you can see, then it does not exist in the mind of many physicians. And that is the problem of chronic pain patients. They don't fit in this thinking. And what we have to change is, first of all, the mind, that when you don't see a pathology and when you no longer find an underlying noxious stimulus, there cannot be a pain. And so many patients are blamed of exaggerating, of malingering, of being hypochondric. And that is one of the problems. It's not accepted that chronic pain is a disease in its own right. And that is one of the major problems we have to face and we have to solve.
I find the whole thing is extraordinary, that clinicians can sometimes ignore people who are in very, very clear pain. Neil, I've been filming in a hospital where in one of the cubicles, a woman was shrieking in pain. And I said to one of the nurses, why aren't you doing something? And effectively, the answer was, well, she should butch up. She should, that she's being weak. I mean, we've got other things to do. We can't just give a priority to the person who makes the most fuss. Is that a common experience?
Well, sadly, it is. And I think the reason, I mean, that nurse in that scenario is probably reflecting the wider societal, psychological aspects that I think other panelists have touched on. It's true that with surgery, you can see the difference in the replacement of the knee, that with medicine, you can see the biochemical changes and the impact of that. From a pain intervention, it's far more difficult. The best measure is probably what the patient says about their pain. But I think in all of this, I don't want to be too negative. I think there are some opportunities. I mean, we are in the 21st century approach to healthcare in Europe, whereby patient-reported outcomes and shared decision-making and the concept of the expert patient who knows what it's like to live with their condition 24 hours a day corresponds and complements the clinical expertise of the health professionals supporting us. So actually, I think in this scenario, we mustn't be afraid of the potential restrictions on pain being invisible. There are things we can do about it. But just returning briefly to the scenario of the policymaker and the support we're trying to get on all of this, we must surely be looking for that special moment when a policymaker says to us, I hear what you're saying, I agree. What do you want me to do? What has to happen? Now, my question at the start of this day to the community here is, do we know? Could we answer that question? Do we have consensus about what good, best looks like? And if we don't, how are we going to get to it? And if we do, why aren't we clustering around that one argument so that we write a short letter, not a long letter?
But the other thing we mustn't forget is I've taken us away slightly from the issue of resources. yes, there's a lot we can do without more resources. It is a cultural change. It is a training change. A change of emphasis rather than saying we've got to have more of stuff. But David, we are going to have more resources to get multidisciplinary teams together, to get people trained in anything, including cognitive therapies and all the rest of it. How big are the problems of persuading healthcare systems to stump up more resource, more cash for this?
I think we need to turn the equation on its head, Nick. It's what are the implications of not doing anything here? The downstream costs that we've talked about of not doing anything are that people in chronic pain access the healthcare system and use more resources downstream. So actually, if you can show policymakers that equation and quantify that pathway, then you might find that they'll engage more readily.
But David, you're a healthcare economist. You know as well as I do that if you talk about downstream problems, so what? Well, it's not that, perhaps I'm being unfair, but most politicians who are in charge of treasury or financial affairs have immediate problems.
Absolutely.
And very severe problems of balancing the books. That's true of healthcare in Greece as much as it is in Denmark, as much as it is in Germany, as much as it is in France, as much as it is in Ireland. So my problem is, if I'm the Minister of Finance or I'm the Health Minister, how do I get through this year? How do I get through this winter? Let alone do I worry about finding resource to stop people coming back in 5 or 10 years.
And maybe it's not 5 or 10 years. Maybe it's 5 or 10 weeks. Maybe it's 5 or 10 months. It's also about investing to save and accept the budgetary constraints. Absolutely, we're on 1-year cycles, 3-year cycles if we're lucky. But it's also about prioritisation. The role of policymakers, decision makers, and commissioners and payers is to try and maximise the health benefit they can for available budget. There's a lot of evidence that suggests treating pain and chronic pain is actually very cost effective in terms of producing healthcare benefits, the quality of life, the quality measures that they use, to try and get pain further up their agenda. So if they're not going to spend on something, it isn't not spending on pain, it's not spending on something else within the system, because that's the equation that they have in front of them. It's a 3 or 4-pronged attack here. It's not a single message. It's a complex message, and we should treat it as such. We should use the numbers creatively, effectively, to almost round on them.
I'm going to, in the next session, ask for solutions. I want you to tell us what you think the biggest obstacle we need to overcome. Is it cultural? Is it financial? Is it training? What do you think? Would you like to start, Maria Teresa?
I think it's cultural.
Cultural.
Yes. Calling things by the right name, agreeing on a plan, and knowing that we cannot take all pain away all of the time, but we're not going to abandon people halfway.
Neil?
Cultural stroke political, but the political belongs to us in this room. So we've been blessed in chronic pain by having some fantastic clinicians and allied health professionals supporting patients, often in very difficult circumstances. But I think patients more and more expect a duty of care from their clinicians and health professionals, which is as much about raising the profile of the disease as it is about the individual treatment. And I think doctors and health professionals have a duty to assist in the effort to raise the profile.
David, I'm guessing as a health economist, you see resource as the big issue, do you?
I'd say quantification. What are the implications at the moment? Where's chronic pain causing the biggest burden? And we've had some figures on that. What can we do about it? And what will be the outcomes of what we do? What good things will happen as a result?
That's a point you were making, quantification and training.
Yes, Nick, I absolutely agree with the panelists and with David's point. I think it's multifactorial, and to add on legislation that imposes mandatory knowledge and skills training, curricula, pain management at undergraduate level. And that is enhanced at postgraduate level, and more people coming into postgraduate who want to train as specialists in pain, who have the skills then to teach undergraduate, because we can't teach the undergraduates until we have the trained postgraduates. So we are caught in that situation. So we need legislation and training and education as well as a cultural shift.
Hans?
It is prioritization, because
there is more money available in our societies than ever. But we have to tell our politicians what we want to see is done with this money. Do we spend it for banks? Do we spend it for military purposes? Or do we spend it for, among other things, treat pain, chronic pain and acute pain in a proper way?
Can I just ask for a straw poll? Just by a show of hands, you might even have some red and green cards in your pack, which might help, but it doesn't matter. I'm going to offer you 3 options, and I'd just be interested to which you think is the most important. So only raise your hand for one of the 3 options. And the 3 are, is it cultural? Is it something that we need to change in the culture, the politics, the social interaction of our society? The second one, is it to do with having proper quantification and proper qualifications? Is it about training? Is it about educating people, particularly clinicians? The third one, is it about resource, about getting more money? Now, they all overlap, of course they do. But it will help in our next session to get a feeling of what you feel here, whether it is this cultural issue, whether it's one of training and learning more about within the professions, or whether it's one of resource, which you think is most important. Could you put your hands up, please, if you think it's a cultural issue? That's the biggest barrier. Thank you. And those who think that it's a trading issue, we need to quantify, we need to get qualifications. That's probably rather more. And those who think it's primarily a resource issue, that our major obstacle is not enough cash, not enough. That's really interesting, that quantification, qualification, getting proper resource is what people seem to feel generally is the biggest barrier.